Hi, everybody, and welcome. Thank you so much for joining me for this talk on clinical decision making, improving outcomes for tough clinical decisions. So, I made this talk because I found that throughout much of my career, I was making decisions that didn't always have sound reasoning. They tended to be a bit subjective and weren't even always research based. And as I'd started to talk to other speech pathologists about this question, I realized that other people were having the same issues. So I made this talk to try to move away from that type of decision making, making decisions with clear criteria, clear factors, so that we know we're using the best information for our patients and moving towards a clear decision making process so that we know we're looking at the full picture. That is what this talk is all about, because I believe that we make decisions that have outcomes that really matter to our patients. Okay, so we're going to talk about specific biases and heuristics, and these are, again, our cognitive patterns of thinking. We all fall victim to them. It's important to recognize that we do before we talk about ways that we can overcome these barriers. So the first four: availability heuristic, anchoring, confirmation bias, and base rate neglect. Availability heuristic. Memorable events are going to have a greater impact on decisions than, say, unmemorable events. So think about you planning a vacation. Right before you plan it, you look in the newspaper and you see that a plane crashed and hundreds of people died. Are you more likely to, say, plan a vacation overseas or somewhere more local? Another version of this might be watching the movie Jaws, and then your phone rings and your friend asks you if you want to go to the beach or if you want to go to the mall. So these memorable events are going to have a huge impact on the decisions that we make. In dysphagia management, this might be a patient that we see who's completely functional, no issues at all. On most of a swallow study that we do, risk factors are very low. And then we see that there's a little bit of aspiration. And so we may be ignoring all of these other factors, such as low risk of aspiration pneumonia, completely functional in 99% of the study, but focus on the more memorable event of that small amount of aspiration, which may lead us to a much more conservative recommendation. Okay, a little bit about decision journals before we finish up. A decision journal is something that I use on a regular basis with my patients, especially if I'm on the fence with something, if it's a highly medically complex patient and I'm not quite sure what to do. So I write down what I'm thinking in the moment, right? What my reasoning is behind my decision, situation, context, the problem, the variables, complications, alternatives. Explain the range of outcomes that might occur, and then what you think is going to happen. And then later on, you would write down what actually did happen. And the reason why this is important is because it helps us avoid hindsight and confirmation bias. So oftentimes when we make a decision and then we see an outcome, we think, oh, I knew that was going to happen the whole time. It's kind of like flipping a coin and thinking, heads, I'm right, tails, I'm not wrong. And so that doesn't teach us anything. It doesn't give us any information that we can use in the future. So writing down the information ahead of time leaves us nowhere to hide. And so when we get an outcome, we can go back and think, what was I thinking at that time? I totally missed this variable, or maybe this worked, but this didn't work. And that way you can use your reasoning and the holes in your reasoning to fill them up so that next time you can have a better approach. It also, just the process of doing this helps us uncover some of those unknown unknowns that we didn't consider otherwise because we're being more thoughtful about the problem. And of course, we're learning as we go to improve our decisions moving forward.